I think what we have shown over the last decade, I already, told you that immune reconstitution is crucial for the outcomes. And there are a lot of variables that can influence immune reconstitution. And I already showed you that ATG is one of the agents used in the conditioning regimens that can impact immune reconstitution. But what we showed before is that also for busulfan, as well as for fludarabine, both agents used in the conditioning regimens, that the pharmacokinetics or the clearance of these drugs is highly variable. And that depends not only on weight or body surface, and this is usually the way how these agents are given, are dosed for the less pediatric patient, but also in adults. And what we showed for these other agents, the busulfan as well as for the fludarabine, is that the highly variable exposure of these agents can have a significant impact on survival. For instance, for busulfan, if you are overexposed, there is an increased toxicity. And this increased toxicity can be liver toxicity, can be more GVHD. While when you are underexposed, there is more graft failure and more relapse. By individualizing, so that's the pharmacotherapy, and individualizing pharmacotherapy, you can target the busulfan to the narrow optimal exposure. And more recently, we showed that for fludarabine as well. We dose body surface based, but what we found in the PK, pharmacokinetic, pharmacodynamic model, was that not body surface, but weight and renal function are predictors for the clearance of the drug. And mainly in all the pediatric patients and in adult patients, the fludarabine exposure was pretty high, resulting in overexposure. And this overexposure was associated with poor immune reconstitution, more viral reactivation, and higher non-relapse mortality. So these three drugs, ATG, fludarabine, and busulfan, if we better target the exposures to the optimal exposure in a certain platform, we can improve the outcomes of transplant and can make transplant safer and more effective. And this is not only true for agents used in the conditioning regimen, but also for agents used as GVHD prophylaxis. My lab didn't work on that much, but others have shown that, let's say, targeting the cyclosporin or the tacrolimus or the CellCept to optimal levels has an impact on GVHD prevention and may also be even prevention of rejection. So pharmacotherapy, targeting to optimal levels, targeting to optimal exposure can make transplant safer and more effective.